So we talk about the endoscopy and the stigmata of the endoscopy. As I said, the stigmata of recent hemorrhage, we are looking for the spurting, if there is clot, if there is visible blood vessels, if there is oozing blood. These are high risk. So high risk, spurting, non-visible blood vessels, clot or oozing clot, these are high risk. The low risk is either pigmented ulcer or clean-based ulcer. Those are the low risk that even you can discharge the patient on oral BBI and discharge him home. Okay? So these are the stage by Forrest score, either spurting, visible blood vessels, if there is clot, pigmented ulcer, and the last one is the clean-based ulcer. It's very important because by which we can look for the recurrence. For example, in clean-based ulcer, the recurrence of bleeding is less than 5%, which is totally different from the patient with spurting more than 55%, the risk of bleeding. So Forrest score, it depends on the endoscopy finding and by which we can predict the mortality and the recurrence of bleeding. This is the tools that we use it, either mechanical method, which is we use hemoclub. We have thermal therapy, injection, but please, injection alone not be used anymore. So usually either injection plus one of the other facilities, but injection alone it's anymore recommended to be used. Usually we have to use it combined with the other modalities, okay? And as we said, hemospray, and usually these kind of tools, it's only bridging. We're talking about the endoscopy therapy, okay? This is the Forrest score. We said about recent hemorrhage, which is Forrest A1 spurting. First 1B is oozing hemorrhage. This is an endoscopic finding. We calculated by endoscopy. Sign of recent hemorrhage, if there is visible blood vessels or adherent clots, if there is pigmented ulcer or clean-based ulcer. This is the spurting we use. This is the different tools of using mechanical tools in endoscopy, like hemoclub. This is the best modalities based on the scoring system. It usually depends on the endoscopy finding, as I said. And lastly, I would like to talk about, we said about the medical therapy for patients with peptic ulcer disease. We put the patient usually on the BBI, 3 days infusion, and after that we put the patient on oral and we discharge him after 3 days, okay? This is the most important thing, is the post endoscopy, 3 days IV BBI, and after that we can discharge the patient on oral medication. Regarding the BBI and the side effect of the BBI, especially nowadays, there is propaganda about the side effect of the BBI. We classify the side effect in spite. The side effect of the BBI is very rare. It's very rare. But they found that the side effect is more common in female. And not only that, they are common in a patient who is using the BBI daily for 365 days. But I recommend you to use it for 6 months, for example, continuously. But I don't recommend the BBI to be used in daily basis for 1 year. It's not recommended. Okay? And especially in female, because all the study approved that it can cause osteoporosis, especially in female. The side effect of the BBI, they classified it on short term, which is 1 month and less, or more than 1 month. Less than 1 month, usually the patient presented with infection, pneumonia, SBB. Do you know that BBI is a predisposing factor for SBB? Patient can present it with diarrhea, microscopic colitis. Long-term using of BBI can cause osteoporosis, vitamin deficiency, especially B12, manganese, magnesium. There is a lot of microelectrolyte deficiency related to using long use of BBI. But again, the benefit-risk ratio for patient who need, the most important thing you have to question, is the patient indicated to be given or not? This is the most important thing to reduce the side effect of BBI. Usually question the indication for patient of BBI. If it doesn't need BBI, please just you can put him on H2 blocker, ranitidine or famotidine or whatever it is. Okay? So this is regarding the, we hospitalize the patient based on this call, either in ICU or, as I said, we can manage him as outpatient phases. Long-term prevention of the bleeding ulcer. This is a very interesting topic, And there is a lot of recent study about it, that how we can recurrent the bleeding. If you want to prevent the recurrence, you have to know what is the etiology. And most common cause of upper GI bleeding, H. pylori. The first one is H. pylori. And the second one of the cause of peptic ulcer disease, the first one more than 90%, especially the duodenal ulcer, is secondary to H. pylori. The second one is non-steroidal anti-inflammatory drug. These are the most common two causes of. Then the other medication that you have to consider in upper GI bleeding is antipsychotic medication, especially SSRI. SSRI, one of the drugs can cause bleeding. And you have to remember, steroid per se cannot cause bleeding. Steroid per se. Steroid concomitant with antiplatelets can cause bleeding. Remember this thing. The other important factor, but steroid per se is not our cause of bleeding. Bleeding, I'm saying bleeding, not ulcer. There is difference between ulcer and bleeding, okay? So the other important causes of upper GI bleeding you have to look for, especially in patients who have multiple ulcer or atypical duodenal ulcer with diarrhea, flushing face, not responding to BBI, you have to look for Zillinger-Ellison syndrome. If all these causes are excluded, then you have to think of out of the box, look for Crohn's, look for malignancy. And if the patient not improve after 6 months of BBI in peptic ulcer disease, please, you have to rule out malignancy and you have to rule out peptic ulcer disease, or you have to ask yourself that the patient, he was taking the medication subtherapeutic or not. So regarding the H. pylori, the recommendation now it changed. Please, it's not anymore recommended to give your patient triple therapy. Not anymore, please, colleague. Now the recommendation, you have to give the quadruple therapy. You have to give BBI plus amoxicillin plus clarithromycin plus metronidazole. You have to give 4 drugs. They found that it's not more, especially in our country after this time, they found that there is a huge resistance to clarithromycin and metronidazole, and the metronidazole more than the clarithromycin even in our country here. So please, not anymore try. You have to give the patient 4 medication, for H. pylori eradication. Now the question, shall every patient ask him if you have H. pylori? Shall I confirm the H. pylori eradication? Please, no. It's not recommended at all to bring your patient to it to make sure that he is eradicated or not, except in special condition. In special situation, you have to make sure. Patient with gastric malignancy, adenocarcinoma, if he has H. pylori, you have to make sure that H. pylori is eradicated or not. Patient with active upper GI bleeding, you have to make sure that it's eradicated or not. Patient with maltoma, you have to make sure that you eradicate H. pylori or not. Not patient with any dyspepsia, please, you found it positive, you bring and give all the people to eradicate, to make sure. So please, not every patient you need to make sure that the H. pylori is eradicated. There is only special situation. This is one of the way of treatment that you can decrease the recurrence of bleeding by killing this organism. The other important issue is regarding the non-steroidal anti-inflammatory drugs, aspirin and anticoagulant, and it needs a very long time to explain, but I will try to give you the latest guideline regarding the non-steroidal anti-inflammatory drugs. The first question that you have to ask your patient, is he using the non-steroidal anti-inflammatory drugs as primary prevention or secondary prevention? Primary prevention, please stop it. If he is using non-steroidal anti-inflammatory for primary prevention, means that there is no disease, still the disease not happening, because secondary prevention means that this is both disease happen, right? So if there is upper GI bleeding and that patient was using non-steroidal anti-inflammatory and the indication was primary prevention, please stop it. If it is secondary prevention, here we have to talk. Secondary prevention, high-risk patient or low-risk patient. Yeah, sometimes now the Dr. Said Al-Wa'ir, he will call me for acute MI with upper GI bleeding. And he would like to start. He wants to save his heart. He wants to save the heart of his patient. And I would like to save the stomach of my patient. But the question here, who is precious? The heart or the stomach? Remember, the heart is more precious than the stomach. The heart more precious than so. All the people, all the organisms are precious. But remember, the heart is more precious than the stomach. Here the guideline is said what? If the patient is high risk, and the patient has active bleeding, I will stop everything. I will control the bleeding. I have a right to control the bleeding within 3 days. So I will tell him stop everything for 3 days. I have a right to stop the antiplatelets, aspirin, Plavix for 3 days. And the recommendation for high-risk patient, they said 24 hours. From 24 hours to 3 days. In the past, 2012, now 2016, in the past can go to 7 days. Now 3 days for patient acute MI high risk. But the bleeding secondary to MI is totally different, Dr. Said. Because if the bleeding is secondary from your medication, my rule is very minimal. And the prognosis, I don't have to play with the patient. For example, acute MI, he received thrombolytic therapy, he developed bleeding. The rule of endoscopic management and the prognosis is not good. I don't have to do too much for him. But if the patient has bleeding and then he developed MI, which we call secondary ischemia, here I can't help him too much. Because the MI is secondary to bleeding. Here the benefit is too much. But remember, the rule here of MI, there is a lot of score to calculate to know the benefit-risk ratio for those kind of people. Regarding the non-steroidal anti-inflammatory drugs, remember, is it primary prevention or secondary prevention? Secondary prevention, you have to benefit the risk ratio for those kind of people. This is the important thing about the non-steroidal anti-inflammatory, even for anticoagulants. So this is the whole thing that I would like to, and I would like to take the home message at the end, that the resuscitation risk assessment, pre-endoscopic management is very important. The endoscopic management and the different type of endoscopy management is very important. Pharmacological, we said, one pre-endoscopy you have to give the prokinetic and BBI, and post-endoscopy you have to give the BBI for 3 days. Post-discharge you have to take care of the H. pylori and non-steroidal anti-inflammatory drugs. And I would like to thank you for your attendance, and if you have